Swelling, bruising, the eye is swollen shut. You're staring at it and wondering how you're going to examine an eye that you can't see. I'm Dr. Jasper Trotter, I'm an ophthalmologist, and I've been in this position. It's hard, which is why I put together this video. I'm going to share what to do and when to call ophthalmology. First, what to do. After ruling out life-threatening traumas, do a quick external assessment. And this just takes seconds. The goal is to get a general sense of how bad the trauma appears to be. It's kind of like surveying the scene, except in this case, you're surveying the eyes. So what are you looking for in this quick assessment? Location. Does it appear that the trauma hit one eye or both? Just keep in mind that an eye may initially look normal, but that doesn't mean it is. The degree of swelling and bruising. When it's significant, that's concerning that the eye or orbit may have also sustained trauma. The status of the eyelids. Do they appear intact or is there a laceration? If there's a medial laceration, assess for involvement of the tear duct. That's going to need to be repaired, generally by an oculoplastic surgeon. Do the eyelids feel soft and normal or firm and tense? To do this, gently palpate the lateral area of the eyelid with a gloved pointer finger. It's important to avoid direct pressure on the eye, especially when you don't know the status of the eye. So this should not be putting any pressure on the eye. It's lateral, and you're really just trying to get a sense of, do the eyelids feel very taut and firm, or do they feel normal? This is a quick assessment to gauge the possibility of orbital compartment syndrome, which is important to rule out as soon as possible because it's an eye emergency. If there's enough suspicion, a lateral canthotomy canthelysis is recommended as soon as possible, even before imaging. In general, if there's any concern for an open globe, avoid any direct pressure on the eye. Next is their blood. Active bleeding could be a clue of a laceration of the skin, like the eyelid or elsewhere on the face, and that might be obvious. But what might not be obvious is that the source may be the eye. Also, look for dried blood along the lash line. Sometimes the eye won't open because it's stuck together by dried blood, and once it's removed, boop, the eye opens. Also, look for a foreign body and discharge. If it's mucopurulent, that's concerning for an infection, but if it's clear and sticky, that's not consistent with mucopurulent discharge in an eye trauma, that's concerning for possible vitreous, especially if it's right along the eyelash line or appearing to come from the eye. That is an open globe until proven otherwise. If the patient is alert, ask if they can open the eyes on their own. If they can open the eye a little bit, but they report eye pain, carefully put in a numbing eye drop in the small opening. If there's a corneal abrasion or foreign body that's scratching the cornea, the patient may reflexively be keeping the eye closed to minimize pain. So if placing a numbing eye drop leads to the eye opening up more, that's a clue of a potential injury to the front part of the eye, particularly the cornea. Just remember to give the patient a heads up that the numbing drop will sting for seconds before it numbs. Next, examine both eyes as best as possible, including the 5 eye vital signs as listed here. But this may be difficult or not possible in a trauma setting, which is likely why you clicked on this video. Step number 4, make the patient NPO. These are the kind of cases that may need to go to the OR, and it's better to err on the side of caution, just in case. And 5, get imaging. So this is key, and this is going to be the main takeaway from this video. If you can't see the eye, find another way to get a view, of course safely. A CT can help to provide an anatomical view and assess the status of the eye, orbit, and surrounding structures, as well as rule out an intraorbital or intraocular foreign body. Like other traumas, in general, the recommended initial type of imaging in an eye trauma is a CT orbits without contrast with thin cuts. And I really want to emphasize the thin cuts. What's recommended is to really get them as thin as possible, and it can help to put that in the order, like in the comments section. If the cuts are too thick, something could be missed. If you want more details like what to specifically look for on imaging, check out the extended video in the description below. Getting imaging can help to rule in or rule out a diagnosis, but it's an adjective tool. The key is the eye exam. Many eye diagnoses, including an open globe, are a clinical diagnosis. Let's talk about when to call ophthalmology. In general, in a situation where there's significant periorbital edema, there's no view of the eye, ophthalmology consultation is recommended, especially if the imaging is suggestive of trauma to the eye or orbit, it's a pediatric case, or there's any concern for an open globe. Here's a list of examples of when to call ophthalmology. If the exam by ophthalmology is limited, then an exam under anesthesia may be warranted in the ED or the OR. If possible, elevate the head of the bed as soon as possible to help with the edema, especially if you're waiting for ophthalmology to come in that might help with their exam. update tetanus when indicated, and ask the patient if they wear contact lenses. That can help determine if a prophylactic antibiotic eye drop may be needed. And when in doubt, err on the side of caution. If the status of the eye is unknown and it looks like the orbit sustained a big traumatic force, do what you can safely, avoid any direct pressure on the eye, and get the CT scan to get more information. To recap, here's what to do when seeing a swollen shut eye in a trauma. 1. Do a quick external assessment to get an initial sense of how bad the trauma is. Survey the eyes. 2. Ask the patient to try to open the eyes on their own and use a numbing drop as needed, especially if there's an opening, even if it's really small. This could help to open the eye up if the patient's reflexively keeping the eye closed if there's corneal trauma. Just be sure to avoid applying any pressure directly on the eye. 3. Examine both eyes as best as possible, and this can definitely be difficult in these situations. If an eye is swollen shut, you're not able to safely open the eye, and the status of the globe is unknown, then err on the side of caution and jump to the imaging and get it as soon as possible. 4. Make the patient NPO. And number 5, get imaging, which can be very helpful in these situations. Trying to examine a swollen shut eye, it's like standing outside of a house but needing to know what's going on the inside, but the door is locked. If you can't see the eye, imaging is another way to get a view. For eye trauma, that's generally a CT orbits without contrast with thin cuts, as thin as possible. I go more in depth in an extended video where I talk about what to specifically look for in imaging, management, and more. It's completely free to check it out. The link is in the description below. So what about this? That's a subconjunctival hemorrhage. They can definitely happen in trauma, but they can also occur outside of trauma. After seeing many on call and in clinic, I put together a 3-minute video where I share high-yield information. Check it out.